Good day, everyone. Thank you for joining us today for this International Pediatric Ophthalmology and Strabismus Council and International Agency for the Prevention of Blindness joint webinar entitled COVID-19, Impact on Lifestyle and Myopia Progression. The question mark is intentional, and we hope it will help frame the discussion. My name is Scott Mundell. I'm a practicing optometrist from Winnipeg, Canada. I'm the immediate past president of the World Council of Optometry. We are a Group A trustee of the IAPB, who I am representing today on this webinar. The important topic today fits into the vision of the IAPB, which is a world in which everyone has access to the best possible standard of eye health, where no one is necessarily or needlessly visually impaired, where those with irreparable vision loss achieve their full potential. I now turn it over to Dr. Tamara Wignatsky-Jaffe of Tel Aviv University, Tel Aviv, Israel, who will lead our first session.
Thank you, Scott. Hello, everyone. It's an honor to be here among so many experts, or perhaps should I say a very humbling experience. Jason Yam and myself are here on behalf of IPOS. IPOS is the International Pediatric Ophthalmology and Strabismus Council, which is a society that collaborates with international and supranational foundations, as well as NGOs, to promote eye care in pediatric ophthalmology and strabismus around the world. So our members include national and supranational societies in pediatric ophthalmology and strabismus, and all orthoptic societies as well. So if your society is not yet a member, you are very, very welcome to join us. I do need to disclose that I'm on the advisory board for both Novasight and Go Check Kids, but now let's proceed with our webinar on myopia. And hopefully within a few months, this will be again the biggest epidemic of our century after the COVID-19 settles down. So we'll start with two questions. What is the most significant factor in becoming myopic? And the answer most of you gave us, 47%, was near work, outdoor 12%, and genetics very close up with 41%. Let's see our second question. So while COVID-19 has been with us less than a year, what impact do you think it had to date? And most of you answered increase the rate and degree of myopia progression, 84%. So let's see what our first speaker will think about those two poll questions. And it's a pleasure to introduce our first speaker, Ian Morgan. I do apologize to all speakers. Our introduction will be only 3 sentences, although we could have written a whole lecture about your accomplishments. So I apologize to all of you for that. Ian is a visiting fellow at the Research School of Biology at the Australian National University and the John San Ophthalmic Center at Sun Yat-sen University at Guangzhou in China. Ian asked us to mention that he is not a clinician, he's a scientist, and his research is famous and known to all of us for establishing the environmental factors in the development of myopia. His topic today will be on the increasing global prevalence of myopia and its implications on healthcare systems. So Ian, thank you for joining us. Welcome, and please proceed.
I should, in addition to declaring that I'm not a clinician, declare consultancies with Novartis and Essilor on methods of myopia control. I wanted to start to deal with the present situation. What we absolutely know for sure about the current prevalence of myopia. And I think the best way to look at this is to look at the prevalence of myopia and high myopia at the end of 12 to 13 years of schooling, because this prevalence is almost certainly, as the cohorts age, going to spread throughout the adult population. So in China, where the prevalence of myopia is 80% roughly in children at the end of schooling, this prevalence should spread through the adult population over the next 50 years. The situation in China is around about 80% prevalence of myopia at this stage. around about 15% prevalence of high myopia. And of course, this is the big issue that Kyoko Ono Matsui will tell us about. In my own country, Australia, the prevalence is a lot lower. The population prevalence at the end of the high school years, about 30%, and really very little high myopia. Now, this turns out to be composed of two different groups within the population. There are the Australians of European ancestry, where the prevalence of myopia is under 20% at the end of schooling, and once again, very little high myopia. There's a significant component of the Australian population now, which is of East Asian origin. There the prevalence is higher, but it is also significantly lower than in the countries of origin of those students. Although academically, they do every bit as well as their peers in their home countries. This doesn't appear to be a genetic phenomenon. This appears to be the fact that when people migrate, they take with them their attitudes to education and to living outdoors. In Europe, the prevalence of myopia at the end of schooling is very similar to that in Australia. So there's really no sign in Australia or Europe that we're approaching the prevalence of myopia you see in China, Japan, South Korea, Singapore, Taiwan. Now, this picture has implications. What it means, and other people will talk about this, is that for myopic individuals in all locations, optometrists and paediatric ophthalmologists need to use the emerging methods for controlling myopia progression so that we can limit the development of high and potentially pathological myopia. In locations where the prevalence of myopia and high myopia is already very high, 80%, roughly 20%, you need national myopia prevention plans to slow the development of myopia and its progression to high myopia and pathological myopia. There's been good progress on this in Taiwan. Singapore certainly has plans, but they tend to be optional rather than compulsory and depend on parents changing their attitudes. Kyoko Ono Matsui may be able to tell you us about recent progress in Japan, because there were signs that the government was taking notice of the issue for the first time. Now, I want to mention the BHVI World Health Organization projections on the future prevalence of myopia, because they have been exceptionally influential. They suggest that by 2050, 50% of the world's population will be myopic, and about 10% will be highly myopic. I want to make this very simple point, that predictions are only as good as their underlying assumptions. There are many papers written now that say the world will be 50% myopic by 2050. That's only true if the underlying assumptions in that paper are true. The study doesn't tell us what will happen. It will tell us what would happen if the assumptions are correct. And I think there are some limitations to those assumptions, which I think means we need to look at those projections a bit more critically. Now, one of the really important features of those predictions is they predict that the whole world, apart from Oceania and Africa, will resemble East Asia by 2050, using the measures of prevalence that they use. Here we have our two marker areas of, if you like, Asia Pacific high income, so that includes Japan and Singapore, and East Asia, which is essentially China. You can see that on their measures, 50% means an East Asian style. It will increase over the next 30 years, but almost every other part of the world will reach that marker within the next 30 years, apart from Oceania and Africa. Now, I want to show you why that's perhaps questionable. I'll take as a test case Southeast Asia. It's an area I know reasonably well, and I can show you the limitations of these projections. Let's look now. It's important to note that in the global burden of disease areas, Singapore is not part of Southeast Asia, even though geographically it is. The prevalence of myopia in Singapore, around a bit over 80%, about 15% for high myopia at the end of schooling. And these data are for males only. Now, one of the characteristic features of Singapore, and indeed all the other countries which have a high prevalence of myopia, is a very high school graduation rate, about 98%. Another important feature shared by all these countries is they are top performers in the international educational performance tables compiled by the OECD. That's a uniform feature. Let's look at Southeast Asia, which is supposed to be 50, at that level within 30 years. For the Philippines on myopia prevalence, we have no data at all. Indonesia, we have one estimate, not yet published, of about 23% at the end of schooling. Malaysia, maybe 30%. Vietnam, less than that. Laos, Cambodia, Thailand, and almost certainly Myanmar, although we don't have any data, much, much lower than that. On high school graduation rates, you can see none of them reach these really high levels that are seen in Singapore, and none of them perform well in the PISA rankings. In other words, they do not have the intensity or universality of education to move into this epidemic of myopia that we see in East Asia.
Ian, I apologize. You have one more minute.
Yeah, I get to that. So I suggest that there's an alternative approach. We need to get good population-based data on samples of children at the end of secondary school, because that's what will spread through the population. That tells us what the future will be. The epidemiological evidence tells us that myopia increases to epidemic levels when you have intensive schooling and lifestyle changes that limit outdoors. And these are intrinsically not predictable. We can get data once they've happened, but you can't predict them. You have to monitor that. Now, the World Health Organization is working to introduce reporting on refractive errors. I don't know how much progress has been made in this area, but I think it would be very useful if we had reporting on this kind of measure, which needs to be interpreted in relation to the percentage of children completing 12 to 13 years of schooling, because that will give us the best ability to predict the future of myopia. And I'll finish there.
Thank you, Ian. We'll go right to our next speaker, and then we have a Q&A session. Our next speaker is Kyoko Ono Matsui. Kyoko is the chair of the Department of Ophthalmology and Visual Science at the Tokyo Medical and Dental University in Japan. She's also the chief of the Myopia Clinic and Advanced Clinical Center for Myopia. Thus, there could be no one more suitable to lecture us on the management of pathological myopia. Thank you for joining us.
Yeah, thank you very much, Tamara, for your kind introduction. Yes, as Yam mentioned, our government was supposed to start nationwide survey of prevalence of school children myopia in this April, but it was postponed because of the COVID issue. So we probably, hopefully next year, we will have the result. So I will talk about pathological myopia. And actually, I will talk about the results at Advanced Clinical Center for Myopia at our university. And prevalence of myopia is increasing, but this was already mentioned by Ian, so I will skip this slide. Pathological myopia is a major cause of blindness, especially in Asian countries. In this review article, Tien showed that the pathological myopia was ranked as the second to fifth most common cause of blindness in the 4 studies of white populations, and was the most common cause in the Chinese study as well as in the Japanese study. So then what causes blindness in pathological myopia? Actually, there are 3 major complications. Myopic maculopathy, especially myopic CNV. Now it is said myopic macular neovascularization, MNV, and myopic traction maculopathy, and glaucoma or myopic optic neuropathy. And the cause of developing the above complication is eye deformity characterized by posterior staphyloma. Now, according to the Meta-PM study group, myopic maculopathy is classified into these 5 categories. Category 0, no maculopathy, 1, tessellated fundus, 2, diffuse atrophy, 3, patchy atrophy, and 4, macular atrophy. Macular atrophy is almost always related to myopic macular neovascularization. And other lesions like lacquer cracks and myopic MNV, which occur irrespective of the progression of these categories, were considered plus lesions. And based on this study, pathological myopia is defined as the myopic eyes having myopic maculopathy equal to or more serious than diffuse atrophy, or eyes having posterior staphylomas. So the development of diffuse atrophy category 2 is a gateway to pathological myopia. But diffuse atrophy does not impair the vision much. Among various lesions, myopic MNV is the most common cause of the central vision loss in patients with pathologic myopia. It develops in around 10% of patients with pathologic myopia. And actually, anti-VEGF therapies are currently the first-line therapy for myopic MNV. Ranibizumab and aflibercept have now been approved in many countries. And off-label use of bevacizumab has been performed in some countries. And myopic MNV responds to anti-VEGF therapies very well, generally, but in the long term, development of macular atrophy is the problem. For example, this patient at onset, MNV is seen in fluorescent angiogram, and the MNV responds very well, but 4 years after treatment, macular atrophy develops, and the vision has decreased to 0.1. And this patient as well, this patient has relatively large MNV at the onset, but such large MNV responds to the treatment very well, but in the long term, in 6 years, macular atrophy develops and the vision has decreased to 0.08. So to improve the long-term outcome, we need to we need to prevent the development and enlargement of macular atrophy. And the next complication is myopic macular retinoschisis, and this is found in 9 to 34% of highly myopic eyes. And actually, surgical technique, vitrectomy using fovea sparing ILM peeling is effective. And this is an example. This patient had macular retinoschisis and foveal retinal detachment before surgery, and these two are post-surgery, and gradually the retina has reattached and the vision has become better. And finally, posterior staphylomas detection is really important for diagnosis of pathologic myopia, but staphylomas is large, actually larger than the conventional 50-degree photo. So wide field OCT is very useful. And in wide field OCT, this is horizontal scan and this is vertical scan. And actually we can see the staphyloma edge and the staphylomatous area. Sclera is outpouched posteriorly, and we can see edges clearly. And actually, in wide field OCT, staphyloma edges have consistently three main features. First, choroid is gradually thinning from periphery toward the edge of the staphyloma and gradual re-thickening toward the posterior pole. And sclera is posteriorly displaced in staphylomatous area, and also scleral inward protrusion at the staphyloma edge. So by detecting these three features, we can objectively identify staphyloma. And actually, in highly myopic children we performed wide field OCT, and actually 10% of the highly myopic children already had staphylomas. And this is 11-year-old girl, and axial length is 27 millimeter, but she has staphyloma edge here and has three consistent features. So by using this technique, we may be able to identify children with pathologic myopia. So pathologic myopia is defined as eyes having myopic maculopathy equal to or diffuse or more serious than diffuse atrophy, or having posterior staphylomas. Anti-VEGF therapy and vitrectomy are effective to treat myopic MNV and retinoschisis. And with ultra-wide OCT, early signs of staphyloma can be detected in children, and future therapies to prevent the progression of staphyloma are expected. And I'm not sure if the COVID increases pathologic myopia. I think COVID increases the rate of school myopia, but I'm not sure if it affects the rate of pathologic myopia. We will see. Thank you very much for your attention.
Thank you, Kyoko, and for being on time. Questions. First question for you, Ian. Does outdoor activity limit the onset of myopia, or does it also control its progression? Which one, or is it both?
That's a very controversial question. I think the evidence is quite clear that it does slow the onset of myopia. The evidence has gone now as far as clinical trials and indeed implementation at a nationwide basis in Taiwan. So that seems to be working. We can make it more effective by increasing the amount of time outdoors, but that's for sure. The issue of whether time outdoors also increased time outdoors slows progression is still a matter of controversy. My view is that the very much seasonal effects we see on the rate of progression tells us one thing, and that is that progression is also modifiable, and probably by environmental exposures of the same kind that affect onset. There's now some evidence emerging from studies in Taiwan of the first positive direct evidence of time outdoors on progression rates. But this is an area where we need a lot more work to be sure.
Okay, question for everybody. Are there wavelengths that are protective? What about violet light? Do we know anything about that? Do we recommend anything about that?
Well, there is one paper that reports that. I think it's really important that somebody attempt to replicate that study, If the results are as good as in the paper, then this is something we should be looking at very closely, but I think it desperately needs replication.
Okay. Question for all panelists. What practical recommendations regarding protective behaviors would you give the parents? So each and every one of you, just in 10 seconds, please tell me what distance do you advise for performing near work? Do you
Cameron, that's my whole talk.
Sorry?
That question is my whole talk at the end.
Oh, okay.
We might want to defer that till.
So I'll skip that. So actually, you know what? I have a question just for you. With those children being treated for amblyopia with atropine, do you have any data regarding them developing less myopia?
We studied that in ATS1 in the first study and did not find progression. That, of course, was using 1%, but it was unilateral, and our marker was anisometropia. But you know, it's amblyopia probably not an ideal model, but again, that was daily unilateral 1%. So that was published probably a decade ago because we thought we would see it. I mean, that was the hypothesis and did not.
Okay, thank you. What about the size of the tablets we use? What about phones compared to tablets, compared to computers? Would you recommend people getting their phone attached to smart TVs? And with all of us being aware that we have babies and toddlers seeing a lot of content, even for a lot of hours at the age of 4, 5, 6, 10 months, 12 months, 1 year, 2 years, what do we recommend, especially since most of us sit around and look at our phone many hours a day? What do we tell them?
Well, that's what I'm going to recommend in the next half hour, not on basis of much data.
I think this is the problem in the area, that we actually have very little data that implicates screen time in the development of myopia. We've in fact got two quite contradictory sets of data. One from Taiwan, which suggests that as use of digital devices has increased, the prevalence of myopia in younger children has gone up. And one piece of data, and we can thank Jason Yam for this, from Hong Kong, which suggests that despite a marked increase in the use of digital devices over the past 20 years, there's been really no change of prevalence of myopia in 7 to 8 year olds. So completely contradictory data on the surface. I think we really don't know, and we certainly don't know whether digital screen time is in principle different to simply reading books.
Okay, one last question for Kyoko. Do you think the amount of surgery and treatment for pathological myopia is matched by the increase in the rate or incidence of myopia today?
Excuse me, could you say it once again?
With the increase of myopia, do you find that you have more retinal detachments, more glaucoma, more pathological macular changes that in the same rate, or is it much less than we actually do expect?
Yeah, actually, in Japan, it is difficult to estimate the increase of pathological myopia because we have many universities and each university has specialties, and we have many patients with pathological myopia, but other universities don't. And but I don't think we haven't seen a rapid increase of myopic retinoschisis or neovascularization or other complications. So, it is just my impression that, but the pathologic myopia, its prevalence has maybe consistent, has not increased much. But it's just my own personal impression.
Thank you. Rachel, can you get my 2 conclusive slides on? So I think all of you know this gentleman. This is Duke Elder, and I just want to show you or remind you what he already observed and published in 1935. He thought, next slide, Rachel, the risk factors for development of myopia were near work, bad ocular hygiene, and physical debility. And he actually thought that modern schools impede too much books upon young children at an age where they should be playing outside. And he recommended open air pursuits and avoidance of indoor activities, especially in children with genetic tendencies for myopia. So way before his time. This ends the first half of our webinar. Thank you. And Scott, I'll pass it over to you.
Thanks so much, Tamara, and thank you to the two first speakers and great questions as well. For section 2, we're going to look at COVID-19 and its possible effect on myopia onset and progression. Our next speaker is Dr. Jason Yam, Associate Professor and Undergraduate Education Coordinator in the Department of Ophthalmology and Visual Sciences at the Chinese University of Hong Kong. He will speak to the impact changes of lifestyle on myopia onset and progression.
Thank you, Scott, for the introduction. And it's my great pleasure to share in this webinar. I have no financial interest to disclose. I would like to acknowledge my department for all the efforts in the myopia research, including the Hong Kong Children Eye Study, which is a population-based study of 35,000 children since 2015, and the LAM study on the RCT on the low concentration atropine for myopia control. We are building up the Hong Kong High Myopia Cohort and Hong Kong Children Eyebrow Bank. The prevalence of myopia is very high, as mentioned by Ian. In Hong Kong, it's very high prevalence, and by the age of 8, we have 36% of children are myopic already. The etiology is genetic and also environmental, but in the recent few decades, the rapidly increasing myopia prevalence, it supports a very strong role for the environmental factors. Parental factor is an interesting factor. It includes both the environment and also the genetic. And we found that if both parents are highly myopic, the children develop myopia has the risk of 12. And there's many factors examined study for myopia, and two major of them. Number one is education, and number two is the limited outdoor time. Near work is a possible risk factor, I would say, and other factors such as the physical activities, sleep, diet, exposure to smoking are not consistent. Why education is associated with myopia? Because number one, there's very little myopia in the society in which children do not go to school. Within a school system, the prevalence of myopia increases when the children getting older and receiving more schooling, and the children are become better academic results tend to become more myopic. And the myopia epidemic regions tend to have a pattern of early onset of educational pressures. There's many papers supporting the link between the education and myopia. And some papers even suggest that education can influence the role of the genetics such for the development of myopia, suggesting the gene-environmental interaction. In our Hong Kong Children Eye Study, we also found that parents tend to become more myopic and higher severity of myopia if they have a higher education level. Second one is the outdoor time. There is a very consistent evidence for protective effect on myopia development by increased outdoor. About 2 hours per day, outdoor is protective. One of the theories is because of the increased dopamine release from the retina under a bright light outdoor condition, leading to the inhibition of the axial length elongation. In 2008, the Sydney Myopia Study found that the increased outdoor time is associated with lower myopia rate. And the 2 hours per day is also can eliminate the additional risks induced by the near work. These are further confirmed by 2RCT, and which shows that it can reduce, as Ian mentioned, it can reduce the myopia incidence. Whether myopia can, the outdoor time can prevent or can slow down myopia progression is still under controversy, under investigation. But this data, this RCT demonstrated that the outdoor time can also slow down myopia progression by lowering the risk by 54%. This is a very important report, as also mentioned by Professor Ian Morgan. In Taiwan, they have a national program implementing the myopia prevention program 2 hours per day. And it is the first report to suggest the public health control policy for implementing increased outdoor time. After 2011, there is a reversal of the increasing trend of the decreased visual acuity, which is a proxy for the school myopia in Taiwan. Near work is generally regarded as an important risk factor, but the correlation was not as strong and consistent as education and outdoor time. Both increasing the reading time and reading distance are associated with myopia. Our Hong Kong Children Eye Study also suggested that the shorter reading distance, the more myopia. The meta-analysis reviewing, including 27 studies, suggesting there is 2% increase in the risk of myopia for every 1 diopter hour more near work per week. Whether screen time is associated with myopia is less established because the epidemic of myopia occurred well before the common use of electronic device. And the prevalence was already very high in Taiwan, Singapore, and Hong Kong date back for children born in 1960. But however, I still believe that digital device is a very significant form of near work. And some recent study also suggest the myopia and the screen time. This study suggests that the computer use for kids for a very young age is moderately associated with myopia development. The lifestyle has been changed by the COVID-19 pandemic. The question is myopia increased during this period? According to, we noticed that there is 160 countries has closed down the school, affecting nearly around 90% of the world student population. What we concern is, number one, the increase of screen time. Number two, increase of the near work. Number three is decrease of the outdoor activity. And there's a few reports starting to discuss on this issue now. In Hong Kong, we have the school closure since February this year with home confinement, and also that all the learning from children become converted to online. We conduct a pilot study to look into this issue. We reviewed, we include 283 children aged 6 to 8 from our Hong Kong Children Eye Study. They have been examined during December 2019 and January 2020 before the COVID-19 pandemic. And we examined them in the July after 6 months. And we also captured their lifestyle change by questionnaire. Very alarmingly, the outdoor time is much decreased. Before that, it's not very high already in Hong Kong. It's about 1.5 hour per day, but now it's less than 0.5 hour per day in Hong Kong. And the screen time is much increased. Before the COVID, it's about 1 to 2 hours per day for the screen time, but now it's increased up to 10 hours per day. And the reading time, writing times roughly remain unchanged. It's about 4 to 5 hours per day. But combining the total near work, including the screen time and the reading time, it has much increased from 5 hours to 15 hours. And the change, we noticed that more than 80% of children progressed, and more than 30% of them progressed by 1 diopter. And we compared our data with a 3-year cohort follow-up, ongoing follow-up in our Hong Kong Children Eye Study. For this cohort, there's on the mean of 0.5 diopter change, comparing in the past 6 months, comparing to over previous 3 years, there is 1 diopter change in the same population. So to summarize, here is last slide. Education, outdoor time are 2 major factors for children myopia. The near work are possible risk factor. Decreased outdoor time, increased near work in Hong Kong are observed during the COVID-19, and more than 30% of children progress by more than 1 diopter. And roughly there is a mean change of 0.5 diopter in the past 6 months, comparing to 1 diopter progression in the past 3 years. I would say there are possible increase in myopia progression in Hong Kong children during this pandemic. I would like to thank my department and my team for all the work. Thank you very much for your attention.
Great, thank you very much for that, Dr. Yam. I'm sure that will give a lot of questions going forward, and we'll look at those in a minute. Now we have Dr. Michael Repco, Professor of Ophthalmology and Vice Chair for Clinical Practice at the Wilmer Eye Institute, Johns Hopkins University in Baltimore, Maryland, United States. Dr. Repco will speak to what can we do during the pandemic to prevent onset, slow progression, and prevent myopia progression in children.
Thanks very much, and thanks for the opportunity to get together with you today. And Jason, amazing data. I suppose it's exactly what my iPhone has been telling me about my own behavior, though. So a couple disclosures. I am chairing a low-dose atropine study here in the United States to see whether or not the findings in East Asia are replicable, and monitoring the events of Luminopia 1, performance of a randomized controlled trial for amblyopia treatment. And I would argue the data on environment and myopia control progression are evolving rapidly, are limited, just as the speakers have said, and that's why even the very extraordinary data that Jason just said are really interesting to most of us. Almost like the chat at the beginning of this call, and when Ian was speaking, the answer to this question used to be easy and intuitive: what to tell children. Tamara reached back to Duke Elder, but in fact we can go back further and probably way before Harmon, prior to the last pandemic. And this reduced near activities was, is a 100-year-old tradition. And the speakers before me have said that, outdoor time seems to be important, but everybody looking at the data has to remember that outdoor time is generally inversely related to near indoor time. And so there is a risk of confounding that has to be carefully monitored. But there is reasonable research that there is a modest effect in older students slowing progression prior to the pandemic. Now, research since 1916 has moved away from accommodation as the mechanism and started to look at outdoor light intensity and other environmental factors playing a role. And lastly, as is often said by every expert in the field, this whole idea of outdoor activities is probably a good thing for children anyway, and so that we should be using both of those measures, health and vision and refraction, as public health measures for policymakers to actually begin to intervene in this area. So what to do? Well, in the COVID period, of course, it's largely going to be opinion-based and extrapolation of other approaches that we might do or parents might have decided. It continues to seem logical to me that less screen time and probably more breaks, particularly as schools do, at least in our country, hybrid versions where the children are doing or asked to do 4 hours straight, is not logical. But breaks are probably necessary. Obviously, we can ask those children in Hong Kong and in Baltimore to go outside in between or when they're having breaks in the school curriculum. And then the other measures for myopia control, low-dose atropine, progressive ad glasses, bifocal contact lenses, all ought to be looked at and perhaps even prescribed more when we have the time to do it. And lastly, no one really knows about combination therapy, but it also seems logical to intervene with those things. So less screen time or dividing screen time up could lead to fewer eye strain symptoms from video displays, which of course is parallel to the myopia progression, but different. And we all know that the whole issue of VDTs and asthenopia have long been an issue, and it's probably an issue for our kids today. So break up the Zoom sessions in the curriculum design, reduce other asthenopic factors like glare off the screens or uncomfortable or positions maybe that children find comfortable but adults couldn't sit in for more than a few minutes. The monitor, remember that people who look at the monitors tend to not blink frequently and try and monitor the children for dry eye symptoms and even consider treatment of those. Reduce headaches by reducing screen time and maybe even reduce other symptoms of weight gain and so forth. The issue with indoor lighting came up already. Increased light intensity in the room, which every mother in this audience knows must be true, has some data that it may slow myopia onset, but exactly how and the wavelengths for that and the amount of lighting are unknown. And someone alluded to a larger screen display instead of laptops and tablets when possible. I think that's reasonable for some things so that the children could sit a little bit further away and not stress their accommodative mechanisms. Again, that may or may not have any relationship to myopia, but it sure could to eye strain or fatigue on the video display terminals. I think that there's pretty much unanimity on the panel on this call. More outdoor time is less myopia. Doing that during the pandemic makes sense. I mean, if the children are not in the classroom, the parents or the caretakers should be able to figure out a way to make that happen. As one or more of the speakers mentioned too, we think that this is related to dopamine, and dopamine in the retina is adjusted or altered by outdoor light exposure. There are innumerable studies Jason and Ian mentioned, two that I just highlighted here, using outdoor time just 40 minutes rather than the 2 hours that they want to do in Taiwan, did reduce the rate of onset by 9% and reduced a myopic shift compared with a control group by a modest amount. Again, if you look at that 0.3 diopters over 3 years, is modest. It is comparable, however, to some of the other interventions. But numerous questions for everybody remain on how much outdoor time is optimal, what's practical, the quality and intensity of the light are unknown, and exactly what the quantitative impact would be on different populations around the world, a lot of unknowns. Low-dose atropine, of course, is become sort of the go-to treatment after outdoor activities. Doses being described from East Asia and being studied in Europe and North America range from 0.01 to 0.05%, and they do slow progression by 30 to 50% in normal school settings, meaning with no other behavioral changes. The drugs continue to have minimal side effects, but are largely have no or minimal regulation of the quality of these drops, how it's compounded, and how the vehicle is used for the drops. So there is uncertainty about its effect in different populations, and also uncertainty about how actually the formulations may vary study to study and country to country. And of course, study outcomes could be related to additional factors that were not identified in the communities where they were conducted when we saw differences in how well the drugs work in, for instance, Singapore versus Hong Kong. In terms of education, these don't really bother the kids doing in-school education, and I don't think that they would be of any problem at home either. Bifocals are often used, often with just modest supportive data. Proponents are divided between segments and progressive ad lenses. The rationale, of course, of these was to reduce accommodative tone and whatever effect it might have on axial elongation. On the other hand, it might also just help with some asthenopia for constant viewing at near. Two studies in this area that I'll just highlight because of the dose effect. So in COMET, there were 3-year increases in myopia in both groups. So notice both groups progressed 1.28 and 1.48 diopters with a difference of really a modest 0.2 diopters over 3 years. Not going to really bend the curve too much. And that's why those authors now, almost 20 years ago, said, you know, we don't know if this is really worth it in clinical practice, but something to consider. A second study looked at a subgroup who might have had better effect, and that was in children with accommodative lag. And there they found, again, over 3 years, both groups progressed, and the effect of the bifocals was still pretty modest, just 0.28 diopters over 3 years. So again, clinically significant, maybe. Statistically significant, yes. Other treatments, currently, Ortho-K is going on worldwide, and then peripheral myopia defocus lenses. MySight, a Cooper product, is available in the United States. and off-label use of biofinity single vision and multifocal D contexts have been used in the BLINK study. And the BLINK study is important here because it was published just 2 weeks ago in JAMA. 294 children of a early elementary school age group with a large range of myopia. And you can see the impact of the baseline, the single vision lens children progressed -1 diopter, which actually in 3 years was less than you would have expected in that population of myopic children. And there was a modest effect in improving the outcome, so that if you take the high power ad contact lenses, it protected about 0.4 diopters over 3 years. So again, fairly modest. So in summary, myopia control measures that we were doing before the pandemic remain important during the pandemic. Some children may not have as much outdoor time as they did when schools organized those periods. Note Jason's data. Some parents might be interested in providing some of these interventions now that they have the children at home, or are at least home more often to monitor it. But in general, the myopia control and myopia progression interventions are not very powerful on an individual basis. And that simply remains a problem in this field, that we're still looking for that next best treatment. So thanks very much for your attention, and I look forward to the discussion.
Awesome. Thank you so much to both of you two, and to certainly all 4 of our speakers today. I'm going to go off topic a little bit here. We're talking about myopia. One of the questions that came in, and I see we have 200 participants, which is excellent. Here's a question. Would your recommendations be different when seeing a hyperopic child with hyperopia background in the family? Do you think all of these myopia risk factors can diminish hyperopia in a hyperopic child? In other words, should we take advantage of these things to reduce that? And I you know, not to shun hyperopic patients, but I think it's just out of curiosity, it's a bit off topic, but does anybody have an opinion on that?
Well, I'll start and say I don't have a good opinion other than to say that's a common lore, that if you make a hyperopic patient accommodate more, they will adjust. And we tried to study that in accommodative esotropia and couldn't prove it. I don't think there is sufficient data to say that or to note that. But at least it's a hypothesis.
From my clinical experience, I found that those with high hyperopia tends not to progress very much, even though they do much near work. I believe they are different from those normal metropization case. So for those who are in Hong Kong, in Chinese children, they progress quite fast. So we will use the reserve of hyperopia to determine when they will have to develop the myopia. But for those who have a few diopter hyperopia, they behave differently.
All right. The other one is, this is probably a clarification on a nomenclature, or what is the difference between, oops, it just moved on me. I was reading off my screen.
Yep.
What is the difference between education, because we know with more education there's more myopia, and near work activities? Do you consider near work / reading as part of education, or is there any separation of the two that, you know, is it the education and or the reading, or a combination of that?
I believe the education using a more objective education level in terms of number of school years, these are more objective to define the education, and also the education system, the internet academic performance. For we believe many of us postulate that education is modulated through the near work, but it's not a very direct equality. It doesn't mean that education equal to near work. For the near work, so far a lot of data are collected based on questionnaire, or how many books they read, how long they read on the questionnaire, in terms of all these data. So it's a little bit different. So that's why the data from the education, I think Professor Morgan will supplement, that from the education level, it's very certain, but for the near work data, it's a bit less consistent.
Look, I think that's absolutely correct, that the correlation between education and myopia is very, very strong. I'll point just to one subtlety in this. In Hong Kong, most children will be getting 12 to 13 years of education, and they do in Australia. But the prevalence of myopia is 4 times higher in Hong Kong. So it's not a matter of simple years of schooling. There's something about the intensity of education in East Asia, which adds up to high performance in the international tests of educational achievement. We don't understand entirely what that difference is. Some of it may well be simply early onset of educational pressures that get kids on the road to myopia and high myopia very early on. Whether it's just near work is a totally different question. The correlations with near work are much weaker.
Scott, so I was sort of hearing a question that somebody asked whether the intensity of the action doing schoolwork versus sort of pleasure reading are equivalent in terms of their near work impact. I mean, so I think that's how that, and I don't think we know that other than schoolwork tends to be, it'll depend to differ on the particular pupil, and so that confounds it. But I don't think we can say, Jason, for instance, in your work that you could separate, you know, that child who does 50% near reading and ignores their schoolwork versus the child who does no reading and does all their schoolwork. That's a granularity probably we need to understand, but we don't.
Thank you to all our speakers. I know we're approaching the top of the hour and we want to be respect everybody's time. One final anecdotal comment. We in my practice were closed for about 7 weeks and started back up in May. Your comment, Michael, about eye strain and sort of misunderstanding of patients. One of my partners had a patient who convinced their physician that they were sure they had a brain tumor, went for an MRI, and of course it was just eye strain from too much computer work. They went from 2 hours a day to 12. I happen to be a teacher, so we need to keep that in mind as clinicians. Anyway, thank you very much to the speakers for taking your time. All of your research, all of the work that you do is very, very, very helpful. And you guys are all pillars in this field. To all of our people attending, we hope that you have found this webinar useful. We have more interviews and recorded webinars available to view as part of the COVID-19 and eye health series that are available on the IAPB website and social media channels for you to view. You can also find further upcoming webinars, articles, and resources on our COVID-19 resources page. So go to iapb.org. I don't have the website address for IAPOSC here, but I'm certain that there are similar avenues for that as well. So once again, thank you everybody for your time today, and stay well everyone. Thank you.